Aishwarya, please. She is speaking on a case of infraorbital schwanoma when the tumor chooses to arise from somewhere else.
Good morning, everyone. So introduction about schwanoma is that it's a benign encapsulated tumor originating from the proliferation of Schwann cells of myelinated peripheral nerve sheaths. Incidence of malignant transformation of this tumor is less than 1%, and it is associated with syndromic disorders such as neurofibromatosis type 2, Carney complex, and schwannomatosis. Infraorbital schwannoma is a rare benign tumor originating from infraorbital nerve, which is a first branch of trigeminal nerve. It can manifest as a slow growing mass in the cheek region. So about the case, a 46-year-old male presented to the Squint clinic with complaints of outward protrusion of right eye since 6 months, insidious in onset and gradually progressive, painless. Previous CT orbit done elsewhere showed evidence of pseudotumor and lymphoma, and hence was referred to a tertiary center. Patient is a known case of hypertension since 5 years on treatment, and family history and systemic examination, nothing was significant. The visual acuity was 6/6. Color vision, extraocular movements were within normal limits. Ocular posture had 15-degree exotropia. Anterior segment was within normal limits. On inspection, there was axial proptosis. On palpation, fingers were insinuated between globe and orbital rim, and tenderness was present laterally. On exophthalmometry, palpebral fissure vertically on the right eye it was 11 mm. Horizontal measurements were 33 mm, and axial measurements was 24 mm. Vertical measurement was 24 mm. This is the pre-op photo of the patient. The first photo, it shows axial proptosis. The second photo is of the axial section of CT orbit, which shows the hyperintense lesion which is present inferolaterally, somewhere between the inferior rectus and inferior oblique muscles. Initially the during transconjunctival approach was made, and tenons was dissected inferiorly. The inferior rectus and inferior oblique muscles were identified, and between the orbital rim and the inferior rectus and inferior oblique muscles, the tumor was identified, and through blunt dissection, the tumor was excised. Grossly, the tumor measured around 30 into 1.5 mm, and on histopath, it showed biphasic appearance of antony A and antony B cells, which were spindle type cells of hypercellular and hypocellular in nature. What was unique in my case was that lesions in head and neck region account for 25% to 45% of extracranial schwannomas, but it rarely involves trigeminal nerve and its branches. So clinical implication could be we can consider schwannoma as a differential diagnosis for this, and orbital schwannomas usually present as painless proptosis. The chances of recurrence, intracranial extension, and malignant transformation are higher if the tumor is highly cellular on histology or wherever the tumor is removed piecemeal. So the tumor might progress on to pressure effects such as papilledema or optic nerve atrophy or retrobulbar neuritis if not presented sooner. So use of various imaging modalities plays a key role in the diagnosis before surgical excision. Thank you.
Very nice presentation, Dr. Aishwarya.
Thank you.
So, any comments, sir?
Yes. From which institute you are, please?
Minto Eye Hospital, Bangalore.
Okay. For because this is a postgraduate's session, you were when you were doing the orbitotomy, transconjunctival route, you know, the surgeon was putting fingers again and again inside. So we normally try to avoid this because it has to be under direct visualization, hand-on-hand technique, and not the blunt surgery. But still good. Thank you very much. Thank you.
Thanks.
Anything you want to add? No?
So anyways, like I will just like to add, we also do like use our fingers a bit when it comes to the surgery. Though, yeah, you know, I'm not just contradicting it. Like just in few cases we do, because in transconjunctival, it's many a times it plays, depends upon the plane of the lesion. We also do it.
It is always
yeah.
better to be directly
it's-
looking at what you are doing, since you have access to microscopes,
Yeah, it's
fine and
better
good
than-
instruments.
yeah,
So
obviously.
always, but I'm just
Yeah.
feedback to
It's
the
always better
postgraduates
that
to
you should
have
directly
a,
visualize it
directly
before.
visualize what you are doing.
One point I wanted to add, because when you were mentioning about exophthalmometry per se, you mentioned multiple things. You didn't mention the base prism, like you will use the hurtles, right? Or use some other. And you, when you're talking about hurtles, we talk about just the axial proptosis. You have mentioned about vertical as well as axial proptosis. Vertical, how did you measure vertical? We usually don't measure. We just do like ideally you're supposed to use scales for measurement of palpebral apertures, not just Hurtle's exophthalmometer. It's just for the axial proptosis, which is readily used.
So what he means to say is that it's an abaxial proptosis. Hurtles is not the instrument to be used.
Okay, sir.
That's what he wants to say.
Okay. Anyways, a very nice presentation.